A mature cataract is easily, safely, and comfortably treated with phacosection. A 6 mm combined conjunctival flap is raised. About a millimeter or two behind the limbus, a straight scleral half-thickness incision is made with a crescent blade. Hemostasis is achieved. A drop of povidone iodine 5% is instilled. 2.5 mm long tunnel is created across sclera, limbus, and the cornea. Anterior end of the tunnel is entered into the anterior chamber using a keratome. Trypan blue is injected into the anterior chamber to stain the anterior capsule. It's evacuated with balanced salt solution using a Simcoe cannula mounted on a bulb. AC is formed with viscoelastic with dispersive HPMC. This is a tunnel fluorentry which is very useful in such situations. The cystotome enters the chamber not through the anterior end of the tunnel but through the floor of the tunnel at the limbus. So you have the full freedom to create a rhexis in a deep chamber without losing it, as the anterior end of the tunnel is sealed and closed throughout the procedure. Few drops of 1% ignocaine is injected under the viscoelastic. As it's being done under topical anesthesia, nuclear management could be slightly painful for the patient when it pushes or pulls zonules and presses on the ciliary body. The tunnel inside is opened to about 6 to 6.5 mm. The nucleus is rotated bimanually in the capsular bag. Its right end, right pole is lifted up and rotated into the anterior chamber. Conventionally, I bisect the nucleus into two pieces using the shaft of a 26 gauge cannula, but here nucleus being hard, it doesn't work. I replace it with the cystotome itself, which is mounted in a 2 ml syringe, through which I am injecting HPMC to separate the nucleus away from the endothelium. The scoring is done to bisect the nucleus into two. Heminucleus is brought to the middle of the tunnel and extracted. The other heminucleus also is being extracted. There is no stretch on the tunnel at any point of time. Cortical aspiration is performed. You need to go to the equator at every point to remove chunks of cortical material in a mature cataract. There is no other tunnel except the main tunnel in this technique. Or subincisional cortex is removed using the right and left Simcoe cannulas. The J-shaped Simcoe cannulas. So ensure that every bit of cortex is aspirated from the anterior chamber and from the capsular bag. IOL is implanted under the protection of HPMC into the capsular bag. As I have an adequate sized tunnel, I do not have to fold or use a cartridge to inject the 6 mm wide intraocular lens into the capsular bag. It's positioned with haptic optic junctions at 9 o'clock and 3 o'clock, which will, in my experience, would drastically reduce the incidence of dysphotopsia. At this stage, all the viscoelastic in the anterior chamber as well as behind the lens and coating the endothelium is removed, so that there is no postoperative hike in intraocular pressure. Keep the pressure to lower side of the normal range. Conjunctiva tenons is closed by fibrin glue, and there is no need for bandaging the eye. Thank you.